Hi, Douglas. Thanks for coming today. Can I just ask you to introduce yourself?
So I'm Douglas Trigg. I'm a GP in Glasgow, and I have various roles within cancer, but primarily I'm one of the clinical leads for the Scottish Primary Care Cancer Group.
So we're talking about lowered gastrointestinal cancer guidelines today. Can you just tell me what the key changes to those guidelines are?
There's quite significant changes in these guidelines, but like all the guidelines, there's some kind of updated context and information on data in Scotland. Where colorectal accounts for around 12% of new cancer diagnoses. The emphasis of the guidance is on early diagnosis to enable more treatment options and improve outcomes. The guidance also highlights some of the issues around inequalities in diagnosis. So the common clinical features of colorectal cancer are listed from the outset, really, also acknowledging that these are very common presentations in primary care. So this leads on to kind of a clinical assessment section, which has been added to indicate the initial tests to be arranged, primarily including when a fit test, or we call them QFIT in Scotland as quantitative fit testing, when it's appropriate, and links to the national QFIT guidance. This guidance also acknowledges that local pathways may differ. But the key for primary care to remember is to know when a QFIT test is appropriate and use your local pathways to facilitate that.
Does your guidance cover iron deficiency anemia, or is that covered in other guidance?
Good question. So within the national QFIT document, it does cover iron deficiency anemia and when it's appropriate to use a QFIT test for iron deficiency anemia. But this is for symptomatic colorectal patients. It is recommended within the guidance that we do a QFIT for patients with iron deficiency anemia where it's unexplained. And those patients may also be recommended to get a second QFIT where the first one's negative.
You just mentioned the QFIT test. What changes have been made to guidelines in relation to the test?
So the most significant change is that QFIT has a new threshold for urgent suspicion of cancer referral that would trigger an urgent suspicion of cancer referral. So that's been changed from 10 to 20. This also aligns to the national QFIT consensus document, which is directly linked into the guidance, and there's a clear on when would be appropriate to offer repeat testing. So if patients have persistent symptoms and a negative QFIT or less than 20, but also sets out which clinical scenarios a QFIT's not indicated. So, for example, it's not a substitute for screening, and it's not appropriate for patients that may have non-specific symptoms like weight loss without specific abdominal symptoms. Having said that, it's important to note that it still may be appropriate to refer people, but not on urgent suspicion of cancer pathways that have a QFIT or a double QFIT with less than 20.
And how does the QFIT for symptomatic patients differ from the QFIT that you use for screening patients?
So essentially the threshold is different. So the threshold for screening patients who ideally don't have colorectal symptoms, because obviously we want them to present to primary care, but that cohort is different. So that threshold is set at 80. As I say, the threshold for symptomatic patients is set at 20. And essentially those thresholds are set because of the positive predictive value of the result plus symptoms or result plus no symptoms as to whether people should be recommended for further investigation.
What's the guidance that you've got for patients who've got rectal bleeding and QFIT?
This is interesting, and it's one of the changes that have come out of the national kind of QFIT consensus document. And the way that it reads is repeated anorectal bleeding without an obvious anal cause should be an indication for doing a QFIT. So if you have just one or two episodes of bleeding and you can find hemorrhoids or a fissure on examination, these patients don't necessarily need a QFIT tested.
The guidelines split into assessment and referral advice. What's the key assessment advice in this part of the guideline?
The assessment part of it is essentially it's meant to replicate what you should do when you're actually seeing a patient before you're thinking of referral. So it's going to be similar for all primary care, regardless of local guidance and referral pathways. But it really just details the symptoms that you should be looking out for, and those that need further testing and investigations, but also specify some of the blood tests that is useful to do. Obviously, a full blood count, but if they're anemic, to prove iron deficiency anemia, whether it's ferritin or iron studies, and when testing for celiac serology might be useful as well. It touches on the importance of abdominal and rectal examination ahead of referral. It also details the scenarios where referral is warranted without doing a QFIT. So if you do find an unexplained abdominal mass or palpable anorectal mass or unexplained anal ulceration, these patients don't need a QFIT, they need just a direct urgent suspicion of cancer referral.
The guideline also covers good practice points. What's included in that part of the guideline?
So yeah, this has been expanded a little bit to, as I mentioned, to include advice on QFIT testing, and also touches on some of the genetics and hereditary colon cancers and how to access appropriate screening, if that's the right word, and assessment of their risk. As well as overlap with other pathways, both benign pathways and other cancer pathways. Also touching on the relevance of thrombocytosis in colorectal cancer. There's a bit more advice also on patients who are unable or unwilling to complete a QFIT, which may be important to reduce some of the inequalities that are highlighted in the kind of the overall introduction part of the guidance, as well as touching on the safety netting advice in primary care to make sure that QFIT results are returned and actioned appropriately. There is a little bit of information on overlap with other pathways as well. It's particularly important where patients have ongoing symptoms but a negative QFIT to consider potentially other intra-abdominal malignancies, be ovarian or renal, potentially crossover with upper GI, and as well signposting to non-specific symptoms pathways, particularly if weight loss is a predominant feature. And also I mentioned the more benign ones, touching on when to refer to an inflammatory bowel disease pathway.